All right. So I think then where we were last time, I don't want to forget to share this. Lordy. All right. I think we were here. And I think we were talking about aldehydes, in particular glutaraldehyde and formaldehyde and such, in terms of being fixative and in terms of what they do for samples. And I'm pretty sure I gave an example of using glutaraldehyde on some of my lab samples when I'd be out in the Caribbean and the Sargasso Sea. We would basically collect them, treat them, and then freeze them. And I'd be able to bring these cells back to the lab and run them on a flow cytometer later. And the flow cytometer, if you guys haven't seen one, really awesome gizmo. It does the cell counts for you instead of the manual click, 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 click. But it also groups the cells into sizes based on optical properties. So I've had some really good luck using glutaraldehyde. But remember, since it does change the structure of proteins, it is a good agent of control on surfaces and even in tissue samples. We were kind of kidding around about the olden days, and the 90s really weren't that long ago, but how many of your cats or how many of your pigs or pigeons or perch or dogfish in A&P or in bio would have been preserved in just vats of formaldehyde and then turned loose into the school or the hallways? If you remember those days or remember being around even 2 years ago when we were dissecting cats and pigs in the labs, the new school version is mostly alcohol. That's only 4 to 5% formaldehyde. The old school version was almost pure formaldehyde. And so, just kind of as an aside, some of these agents of control, and it's lesser so of the new stuff, more so of the heavy metals and the aldehydes, folks used to have their fingers and hands in there. And this was before the advent of gloves, right? We didn't really know better. Maybe we did, but we didn't back then. And if you look at certain older faculty who are probably retiring at the moment, my father included, some of the nails on the hands have really been changed by exposure to some of these chemicals. And so if you think about the ability to destroy microbes and to curtail their reproductive ability, which is the point here, it makes a lot of sense that it would do damage or at least alter how human cells are working. And that's pretty much what we see. And the mutated cells in his hand are really reflected in the rate at which the nails have to be clipped. Obviously, there's some other stuff going on. In addition to, I don't know if you guys pay attention or look at your nails often enough, but sometimes in the nails, there is nail bed underneath, there is skin underneath, so to speak. And you could have melanin produced inside the nail bed. So if you were to look down and see, at least with me, I get blue spots or brown spots that follow the striations of my nail. That's the melanin underneath. And thankfully, the toenails that I've had treated have no nail on them. And so they were easily able to get cell type and do a test on them. And they're just cells with extra melanin. However, some of the mutagens really do cause cancer in the nail beds. And that's just something else to be cognizant of, just for what it's worth. And we didn't hit this last time, and we were dragging on. This stuff can be excessively dry if you don't have a frame of reference. And so just kind of leading off with the last piece of this, gases and aerosols tend to be effective if they're strong alkylating agents. So, we want to add CH3s, we want to break some of those carbon chains, and some of these gases can be very sporicidal. Ethylene oxide for one, but more so the propylene oxide and the beta propiolactone tend to be some of the strongest gases or aerosols that you can produce. With chlorine dioxide, which is a nasty chemical, coming in kind of last, very oxidative, that chlorine dioxide, heavy electronegative elements, the oxygen at 3.5, the Cl, it just wants to rip electrons out of things. And so when you have a chamber and you put in this case, we're doing a discard, so it's gloves and it's stuff that we're just trying to kill. But essentially when you would do a discard, stuff that you want to kill, you can put them in a chamber like this, expose it to an element. There's a dwell time, very much like an autoclave, not so much pressure. And then at the end, you end up having the gas filtered through a pump and put through water to render it, at least, if not inert, not in gaseous form, so that you can take the stuff and dispose of it properly. And I guess this is a conversation we never had. When we do a discard in the lab, what we end up doing is autoclaving it, probably at an hour at 15 pounds and 15 pounds per square inch at 121C. And then we actually box it up and have a medical waste carter come and take it away. So we kill it, they pick it up, they burn it again. And that's pretty standard for dealing with stuff that leaves these kinds of labs. Now you'll notice this particular tech has a lab coat on. And if we were live, we would have asked folks to wear lab coats in the lab as well. And so for folks who do medical work, who work in hospitals, lab coats may be akin to scrubs. And I want to ask the question, where you work, if this is what you do, are you allowed to wear your scrubs to work? And that's different than do people. It's, are you allowed to wear them to work?
What do you mean, are we allowed to wear them to work? We're supposed to wear them to work.
So I can tell you, like at Westchester Med, the folks who are in scrubs actually are not allowed to wear them from home. There's scrub dispensers at the hospital, and people actually change when they get them.
Oh, I see.
And
Yeah, I've seen that. I worked at Good Sam. They do the same thing.
right. So do you ever think, or do you ever ask yourself, that's really inconvenient. I wonder why I can't just wear them there. And the whole point there is cross-contamination. So at a lot of places, you know, when you're at home or where you're riding the train or the bus or driving into work, you're exposing yourself to stuff. And it's maybe not harmful stuff at all. But when you bring that into the hospital, you're potentially exposing clients to the things that you brought in off the street. And it's not a slight against anybody. It's not making a judgment against anybody. It's just a better way to control the environment on the job site rather than have people bringing in their street clothes, well, having them bring in their scrubs and then exposing patients. So a lot of places, you come, you change on the job, you change before you leave, and this way your street clothes only see the inside of the locker. They really don't see the inside of the hospital proper. And I was getting at the point where, you know, a lot of students like to wear their lab coats from the car into the building and then from the building out to the car. And it's the same kind of thing. The reason you don't do that, you put it in a bag and you try to wash it every week, is because you don't know what you're going to bring home from the lab. You don't know who spilled on what surface and didn't clean it. You don't know what aerosols got on your lab coat. And you know, if you have kids or animals or people that are immunocompromised at home, you don't want to bring that in the house. And so it's kind of an extra barrier or an extra safety thing where at some point, you know, that lab coat really is going to be soiled. And washing it separate from everything and keeping it separate from people / keeping it separate from your other rotation is kind of important. So that's why I asked the question. It's not necessarily an agent of control, a lab coat or scrubs, but in a way it kind of is, because if you can prevent cross-contamination, then you're making sure that these microbes don't spread further than they ought to. And I think one of the best examples are the community-associated infections that are born from hospital infections, lordy. And some of them like MRSA, MRSA, if it's in the hospital, and it is, you don't want to bring that home. If Candida aureus is in the hospital, and it is, you don't want to bring that home. If patients show up to a doctor's office, wherever it is, and they've been ill or they've been in a healthcare setting, they may be bringing that stuff to your patient office. Yeah, there you go. There you go. So the PPE is over the scrubs at that point. Right, and exactly for the same reason. And, you know, when all this COVID mess becomes either part of the background, which it's likely, and we get COVID boosters like we get flu shots, which unfortunately is also something that's being entertained, a lot of this, when we go back to normal, may be different, may be laxer. And I would argue, without looking like a crazy person, a lot of this stuff is probably a good thing to keep up, because the pandemics aren't going to slow down, more than likely. The microbes are going to be out there. They're going to get stronger. They're going to be more of them. They're going to be more virulent, different strains. And so this is just good practice. Now, of course, stuff happens, right? And biology is the land of exceptions. We really we can't account for everything. But what little we do have control over, we probably should just be cognizant of that. So hopefully no breakthroughs, hopefully no weirdness, hopefully no contamination. And even still, I can tell you a story about a microlab situation. I might have shared this with you, where there was a young lady who wanted to finish up her experiments, and then go on to take a test. So the lab was like one to what would it have been, 1 to 4:30, and then lecture would have been 5:30 to 8:30. And at the very end of lecture, the student had a test tube in her hand. You can barely see that. She took the cap off, got too close to the flame, and knee-jerk reaction, spilled the E. coli on herself. Now, the student did have a lab coat on, so that was good, but she missed. And underneath the lab coat, there was not an appropriate level of clothing. And by that, I mean there was a sports bra. And so given that she couldn't just change her clothing, we had to give her the option of showering in the field house, and we let her borrow some clothes from the campus ministry, or she could go home and shower. You know, she couldn't stay because she herself was contaminated with E. coli. And the option was to shower, gave her some soap, gave her a bag for her clothes, came back, never caught E. coli, never had a problem, never got sick, thank goodness. Right? But easily that could have gone completely sideways had she needed to wear those clothes someplace else, had we not had her shower, had we not escorted her from the room, because really she was completely contaminated top to bottom with quite heavy loads of E. coli. Could have been bad, could have been transferred to others. And all she wanted to do was take the test in a room where we don't use microbes. And so imagine now the cross-contamination of entering room 1117 after you've left 1100, and you walk in and smell microbes, you don't know where they are, and then you go home and you get sick. So a lot of this cross-contamination thing is a real deal, Now, obviously, had any of us gotten sick, this is what you want to avoid. That is quite a handful of pills, assorted pills and medications. But the idea here is, once these microbes are in the body, or once the microbes in the body overgrow and start to cause problems, we usually turn to drugs and chemical means inside the body to treat them. Since I'm going through this, I have 2 toes on either foot. The 4th left toe and the 5th right toe had some funky nail changes. And some of that is psoriasis, no doubt. But she did a culture. And I think I shared with folks that it had some fungus in it. That maybe isn't too surprising. There's always fungus on us. And there was some staph that was stronger than garden variety. I still have no idea what she meant. I'll find that out on Monday. But because I'm having redness and dactylitis in the toes, she is prescribed some amoxicillin with clavamox or clavuronic acid. And woo, it's a large pill, but boy, does it wreak havoc on me. And as a result, I've been hitting the probiotics pretty hard, mainly through yogurts and live cultures, not necessarily pills, so that I can maintain good gut health. Obviously, the antibiotics are working on the bad and the good. The bad is the staph in the toe, but unfortunately, the digestive ramifications are ever present. So if you're in the room and you've never had an antibiotic prescribed to you, congratulations. I think that is awesome. And if you've ever had to turn that way, awesome. But I think that's probably the exception. There's probably more of us who have had to use antibiotics and or other kinds of antimicrobial compounds in our lives than those who have none. And so I'm sure folks always wonder, is this safe for me? Is this good for me? And how will I feel after taking these meds? I know that's always a question, and it's a good question, especially since we need to take care of our families. We need to take care of the children. We have to go to work. We have to interact in the community. We have obligations. And so these are valid questions. I'm going to tell you, it's an interesting thing when you look and you say to yourself, what am I taking and how am I going to feel? Or you're a physician maybe, or a nurse, and you say, I have to give this to you. And I know you've read the paperwork, but the risk is certainly justified by the means. And you look and you're like, all right, well, you're the doctor, okay. But honestly, it's kind of a dance. So what you see on the screen now are the ideal drugs, or the ideal characteristics of a drug, of an antimicrobial drug. So we mean one that you'll actually take and consume. And the first one is probably the most important one. But remember, the word here, ideal, means that this is what we want in a drug. It doesn't mean we're going to get this in a drug. So the first point is selectively toxic to the microbe, but non-toxic to host cells. Well, we certainly don't want to take medications that are going to make us sicker. And non-toxic means we're not causing death or irreversible reproductive function being removed. What we're not saying, though, is that they don't have side effects. We're just saying that we're only killing the microbe. Now, the idealistic piece of that is great, but let me ask you a question. You have some warts, you have HPV, and you want to take care of them. You're going to have to kill the host cells to take care of the viral cells, more than likely. So a lot of those drugs have to do both. And what they try to do is just not do quite so much damage. There's medications, especially for viruses. Molluscum contagium is one of them, where I've taken medication for 3 days on and 4 days off. And that was a topical because of the cytotoxicity. So, ideal here. We would love them to be microbiocidal rather than microbiostatic, or bactericidal rather than bacteriostatic. Not always possible. And if they are microbiostatic, right, so they take away the organism's ability to reproduce, you need your immune system to be able to come back and smack the cells down, come back and phagocytize them and kill them. If that isn't possible, then you might have to go to an older drug or a drug that's not as happy on the cells, that might be a little more toxic, right? So there are reasons why some of this older stuff still exists. We'd like to see this stuff relatively soluble, and we'd like it to function well, even when highly diluted. So some medications are slurries. They're not soluble very well in water or at bodily pH. That makes dosing kind of a problem. And obviously, the folks in their medical knowledge, you want to use the smallest dose you can to get the therapeutic effect. And with solubility issues and or suspensions, sometimes you're overloading the patient because you need to get enough in them. And when you see these overloads, kidney and liver function are typically the places we look for challenges. So do you want to get rid of the microbe, or do you want to have a healthy liver and kidneys? Obviously, we have to go with the latter, but we need to deal with the former. So that's sometimes challenging. Likewise, what's the half-life of this stuff? How much can you take in a 24-hour period? How much do you have to take in a 24-hour period? And how is it broken down? Is it through an enzyme system? Is it through filtration? Is it just through elimination? What's a reasonable half-life? Is 8 hours enough for a therapeutic value? Is 6 hours good? What happens when the half-life is a day or two? And so you would think to yourself, oh, extended release, that's not always a bad thing. You're right, it's not. But since we're thinking about these agents of control, I'm sure no one's had an allergy or anything to an antibiotic. And so a half-life of a day or two probably isn't a big deal, right? Well, right, back to the real world, nothing's ideal. And so, we want to make sure that what we're doing is safe. And a lot of these antibiotics are eliminated within 24 hours, 8 hours, 4 hours, and excreted from the body in far less dangerous forms. So that's a good thing. But every now and again, you catch one that really is effective, but it's got a long half-life. And as long as you're not allergic, it's okay. If you are, it may be a trip to urgent care for you. Antimicrobial resistance is a big one. And so here's my thought on that. Eventually, the resistance to all drugs occurs. That's just the nature of the business. And once you have resistance, you almost never get rid of it. If you look at streptomycin, resistance happened in 1945 with relation to tuberculosis, 47 maybe. Just recently in 2017, we found a strain in somebody who was susceptible to streptomycin. And don't you know we gave it to them? Because why not, right? It's a low drug. It's selectively toxic to the microbe, but not the host. It's microbiocidal. It's very potent at low concentrations. It's a great drug when it works. And so that's one of these funny things. My take here is this. We learn the lessons from TV, and that's how we prescribe drugs from now on. You never give somebody just one. You probably need to be giving them 3 or more drugs that are meeting many of these criteria in order to really tamp out antibiotic resistance. And I know that sounds crazy, and it is overkill coming from the idea of the lowest dose possible. But if we come at the microbial resistance side, that's the only responsible way to do it. And that's why now with tuberculosis, they give you 4 drugs at a time. We cannot afford to lose another drug in the fight. When you look left and you look right, 1 in 3 people have TB on this planet. And so now when we see 15 drug resistant TB, if we go much higher, we're going to have to say to you, I'm very sorry you're sick. Please go someplace. It's been nice to know you, and don't contaminate others, because that's how dire the situation there is. So moving down the list, does it complement or assist the activity of the host defense? Okay, well, that's what we'd like. If it does, great. We can probably skip some of these other things. If it doesn't, we go back and we say, how toxic is it? What kind of a dose do we have to give? Some of these antibiotics are great. Bacitracin is phenomenal. You can't take it internally. Right? It's just too strong. Your liver will not survive it. So, these are the things that we think about. Is it active in all tissues? What tissues does the antibiotic get to? And how well does it cross particular barriers? If you're thinking stuff like Lyme disease, and you have the bacterium that get behind the blood-brain barrier, how do you deal with that? Well, you've got to select drugs that not only clear what's present, that can get into CSF. And so you're getting the list really, really whittled down. How do we deliver the site of infection? How do we get the stuff in there? Is oral appropriate? Do we need to put this into an IV? And some medications are so bulky in terms of the size of the molecule, it must go into an IV, or something bigger, depending, like vancomycin. How much does it cost? It's sad that we have to think about that. But obviously, a cheaper med is a better med than a more expensive one. A cheaper med gets delivered more frequently to the people who need it than expensive meds. Cheaper meds make it to developing worlds that are really in need. And who cares how much money is made? The cheaper the drug, the less you care. There have been some really messed up things lately. And there's a drug that treats, is it cryptosporidia in HIV patients, that when the company was sold, the drug went from $20 a dose or a sequence to $750,000, of which, of course, the company was vilified, the owner was vilified, and he said, hey, don't fight me here. I have to pay for my other drug discoveries, and so this has to rise in cost in order to pay. And what do you care? You're insured anyway. Well, how far from reality could he be? The ironic piece is that guy's in jail now, so things have returned to the status quo. But equity and cost of medications is ever increasing. The cost and decreasing in the equity, at least in the United States. But since we're doing a lot of the drug discovery, it really screws a lot of other countries and people that can't afford this stuff. And obviously the last piece is, what do we do with allergies? And or does it predispose us to other infections? Does it immunocompromise us? Does it create ulcers? Does it destroy the barrier of defense? Are any of the side effects things that would do those things? And so, since these are ideal, let's face it, you're not going to get all of these. Can we get a reasonable amount of these so that somebody would take the drug, feel better, recover completely, and be willing to go through that again? I guess is probably how I would say what a really ideal drug is. If it hits all these, great. But if you take it and you don't feel terrible and you recover fully and you would take it again, I think you've been successful. And obviously, some of these drugs work, some of these drugs don't work this way, but that's the idea. And so let's see. I'm sure we're all good with these terms, but I'm going to throw them up here anyway. And there's some kind of cool stuff you see, right? Narrow spectrum and broad spectrum, we kind of have an idea. Synthetic and semi-synthetic, probably not a problem. Antibiotics, clearly the case here is bacteria, right? And so really it should say substances produced by the natural metabolic processes of some microbes that it can inhibit or destroy. It probably should say partially inhibit or destroy other microbes. Well, we probably should say bacterium, right? Because we're not using antibiotics for anything else, with extremely few exceptions. One of the antibiotics, I believe the brand name is Flagyl, works on gram negatives, also has some anti-parasitic activity. And so there probably are a few like that, but there's not a lot like that. And then otherwise, the only other two terms in here are the additive and the synergistic effect. And I'm wondering if folks got to see that or talked about that in the lab at all. So additive effects are essentially the point where two drugs work the same by themselves as they do together, versus synergistic effects where you have drugs concerned. Drugs that have synergies work more strongly when they're combined than when they're given just by themselves. And so you might have to use 5 milligrams of one drug by itself, but if you combine them, you might be able to go down to 1.5 milligrams of drug when combined with 2 meds. And so you see these synergistic effects a lot. And I think in the lab we use trimethylprim, tetracycline, and gentamicin. So those are the drugs that we would use if you did the experiment, or just to kind of help you guys remember that experiment. And then the prophylaxis obviously is a good one. Generally, what you want to do for this is give someone a medication prior to needing it, a surgery, an event where they're likely to be contaminated or infected. And this kind of has a lot of other connotations. So most of us are probably thinking dental. My podiatrist apparently is thinking toes. That makes me wonder what she has planned. But the other place that we're seeing this a lot more recently, like the last few years, is on the TV with commercials, right? So have folks seen the commercials for Truvada for PrEP? And what do you guys take out of those commercials, or what do you think of them? Because certainly that's for prophylaxis. I'm sure folks, well, you guys probably don't have time to watch TV, but I'm sure you've seen those commercials at some point. And essentially, it's a strong dose of an anti-retroviral drug that prohibits the action of reverse transcriptase. And so prophylactically, if you take this medication and you happen to be exposed to HIV, the idea is that the Truvada keeps such a high level of reverse transcriptase ACE in the body that HIV would never be able to make its cDNA, would never be able to start replicating, and would thus be eliminated from the body without causing an infection. Now, the downside is you're taking meds for a month before they work, and you're going to continue to take meds for as long as you are at risk and are HIV negative. So you have to hope the side effects are reasonable and that they don't cause people to skip doses, miss doses, or use it in any other way than directed, because there's a lot at stake here. The evidence says it works pretty well, and it's reducing the risk by 40%. And I think that's a good number, given what we know about our attempts at HIV, but nevertheless, that's probably one of the newer places you see it. So if we take a look at some of this stuff, where do we find antimicrobial drugs? Well, I think we touched upon some of that already. We find them in flowers, we find them in plants, we find them in medicinal herbs, and that's a very broad topic here, medicinal herbs. And we also find them as the byproducts of other organisms' metabolism. And so here on the screen, you definitely see streptomyces and bacilli or bacillus organisms that produce a lot of drugs. You see penicillium. Well, we know penicillium makes penicillin, and cephalosporium makes cephalosporin. There's something called Grisia fulvum, and Grisia fulvum happens to make a drug called Grisia fulvin. And Grisia fulvin used to be prescribed to people, it's an oral medication, to deal with dermatophytes and fungal infections. That largely ceased with the production of diflucan because Grisia fulvin was hard on the liver. But if you've ever had a ringworm or just a stubborn jock itch or athlete's foot infection, diflucan along with tinactin is an amazing treatment, or nystatin, an amazing treatment. But it's one of the older generation things, and it definitely has more side effects. And it's funny too, when you look at why the hell would a mold, a fungus, make an antibacterial compound? Nobody likes bacteria. No, that's not right. It's really more about competition. And if you guys are interested, Tillman et al. In the late 70s wrote some great papers. But competition is basically not only for space, but for resources. And so if I'm living in the same place and there's a finite amount of food, you're damn well going to expect me to fight dirty so I can get a morsel to eat. And that's definitely what these bacteria do to each other. That's definitely what the funguses do to each other and to bacterium. Someone's got to go, and they use the chemicals to exclude others so that they can get a chance at getting a meal. So it's not terribly uncommon to hear that you see other microbes being sourced for antimicrobial drugs. One of the more interesting ones is the person or persons who discovered Abreva. And without Googling, I'm sure folks have an opinion of Abreva, right? That's the medicine you get at the store for herpes simplex. Where did it come from? Anybody know? Kind of an interesting drug. It works. A lot of medications for herpes work for cold sores and chickenpox for that matter, although it's off-label. Abreva came from a sea sponge. Right? Somebody found a natural sea bath sponge that produced the active antiviral compound in Abreva. I don't know, did Jacques Cousteau trip and fall on it? I don't know, but that's where it's sourced from. And so when people harvest and grow these sponges, they're growing it for the antimicrobials. They can then sell them to people who want natural bath sponges in their homes. And so it's kind of a really cool quest to overturn roots and rocks and find fungi that we can culture and see what other things they make. I suppose this is what humans have been doing for years in their quest for, I don't know, stronger drugs, stronger meds, different psychedelic experiences. Well, sometimes it's just about the dosing. So something that causes hallucinations at strong doses may be antimicrobial at low doses. That's for the laboratory personnel to figure out. But you're going to see a lot more of this stuff, a lot more harvesting of natural products as what we currently have becomes ineffective. You'll also take this into account here. We've got to be really careful, especially as we move into the realm of eukaryotes that are in the body causing harm, or for long-term infections, for simpler things that we've become resistant to. So a lot of meds you'll see require liver and enzyme testing, which tells you it's really concentrated and or it's really strong / harsh on the body. And obviously, those are not ideal, but sometimes we don't have a choice. And a lot of the times, fungal meds are exactly that. They bother our livers while we're trying to take out the microbes. And since they're eukaryotes, it takes longer for the medication to be absorbed, and it takes longer for it to work. And so, fortunately, fungi and our human cells are a little different via the cholesterol or ergosterol. But some of these things, like viruses, when they get into our cells, or some of the helminths, although we can deal with helminths, it's harder to get rid of, and you start to see more side effects. Helminths are kind of interesting. Normally, we give poisons to them, and you take a small pill. It works systemically. It's absorbed in the GI tract. The organisms are knocked out, and then you pass them. Kind of interesting, but otherwise, toxicity is going to be something I'm sure we look at as we move on. And somewhere in this mess, let me just find it because it is interesting. I had a chart about tuberculosis. And the reason why I find it interesting is because there's a lot of medications on this list. And I want to share this with you just so you get an idea of really why it's important we keep tuberculosis in check. So if we take a look at this chart here, you see, going back to the early 40s, streptomycin, ionazid, we get into the 50s, kanamycin, rifampin, 65. And notice the last TB drug that we made was in 1968. And again, the reason for that is, well, we don't make money because of how quickly TB becomes resistant. And you'll also notice that I've got 4 of these in orange or yellow or whatever that color that is to you. Those are the 4 that we give people as a first line defense to TB. We give you those 4. And they're not exactly easy on the body, but they are the easiest of the combinations on the body. When you start going back to some of these other things, we go back to capreomycin, we go back to kanamycin, we go back to cycloserine. They work, they're effective if the TB is susceptible to it, but it wreaks holy hell on people. You get real sick, you get nauseous, you vomit a lot, you can't keep food down. And that's the reason why people end up being visited by social workers, quarantined to hospitals, hotels. And I don't know why, I've been mixing that up all day. Hotels and hospitals are very different because people can't be trusted to continue to take the meds as prescribed when they're that ill. And I don't blame them. It sucks to be sick and take things that you know are going to make you sick. But again, if you don't get rid of the TB, we already know what happens. So I just wanted to share that with you. These are nasty drugs. And if you start to look at a lot of these, you find out they just wreak havoc on the body. Have there been new drugs discovered since then? Yeah, there have been. And they're not many, but there have been. Doxycycline, minicycline happen to be some interesting ones produced down in Pearl River. But really, the level of new drugs past Levaquin, it's really dipped in the last couple of years. And that's obviously, that should be concerning. All right, so these drugs typically then target one of these four structures or one of these four items. We go after the cell wall. Sure, well, that makes sense. If we go after the cell wall, your body's osmotic pressure deals with the job. If we go after nucleic acid synthesis, either DNA or RNA, you take out the protein portion. Now, this is different than inhibiting protein synthesis. Nucleic acid synthesis, we break before we get to the ribosome. Whereas protein synthesis, we either try to disable the ribosome from being made, or we try to disable the ribosome from binding to make a functional ribosome. What I mean there is small and subunits don't come together. Or we block the E, the P, or the A site within the ribosome. And in the case of TB, we're doing a bunch of this. We're damaging the genes for the ribosome. We're damaging the ability of the ribosome to come together, and we're blocking sites where the mRNA would need to be translated. So we're taking a multi-approach to TB. The other piece is obviously disruption of the cell membrane structure or function. And so in some cases with fungi, we go after the ergosterol and we disrupt the steroids in the membrane. Sometimes we can go after surface proteins or the carbs. It's really hard to go after phospholipids. And obviously it makes sense. If we go after the bacterial ones, we're going to go after our phospholipids. And so that's an area we tend to stay away from. All right, so if we're thinking about targets of antimicrobial drugs, here's one where we work on the cell wall. And up top, you see some happy coccus cells there, some gram-positives, probably a staph looking at the arrangement. And if you look below, whether this is penicillin or vancomycin or methicillin, really doesn't matter. What you're showing here is exposure to a beta-lactam antibiotic messes up the peptidoglycan. And so how? Remember, N-acetylmuramic acid and N-acetylglucosamine cross-link, and they cross-link to strengthen the cell wall. If you remove the ability to cross-link, then the walls are leaky, they're weak. And so in a hypotonic environment, so our bodies relative to, or our blood relative to the cells, water starts to rush in and they lyse, they blow up. And so track E is healthy, track F is the cells exploded. Very similar to what you see when you forget to let the slide dry and heat fix. That's what lysed cells look like. Very, very effective. And there's a lot of these beta-lactam or cephalosporin-like, penicillin-like drugs that actually have this function. And in general, we find that they're pretty well tolerated. So you kind of look here and you see what the story is. It's the peptidoglycan, and it's really the cross-linking that we blow up. Penicillins and cephalosporins are the two classes of drugs that typically have a lactam ring or more in it. And you'll notice that, and I need to qualify this statement, penicillins, and I'm going to change it a little. Penicillins have problems with gram negatives. They do. There are different versions of penicillin. There's penicillin B, there's penicillin G. And so if you are diagnosed with a gram-negative type infection that is susceptible to penicillins, you get the formulation that will allow you to cross the lipopolysaccharides in the gram-negative to actually disrupt the peptidoglycan in the cell wall. And so it's a slightly different formulation, but it does work. And I can tell you from and this is going to sound super weird to folks, having friends growing up that were doctors, my folks always had some prescriptions in the house. And arguably, that's not the right way to do it, but they felt it was okay and they trusted my parents enough. And on occasion, I would get penicillin shots. It was stuff the clinics were throwing out. They were expired. Now, let me tell you about expired medicine. The expiration date is set so that when it's 90% effective remaining is when it expires. It doesn't mean it's useless necessarily. It just means that 10% of the efficacy is gone. Now, for antibiotics, that might be one thing. For some medicines, you have to be careful because they do break down into some toxic products, or they become very acidic and can cause burns, or they're just not going to function anymore, like aspirin. Aspirin, not generally antimicrobial, but aspirin is funny with the expiration dates. If aspirin expires and you've kept it in a cool, dry place, and you open it and it smells fine, have at it. If you open an aspirin bottle and it's from 1962 and it smells fine, have at it. If you open a bottle and it smells like vinegar, throw it away. It's degraded. And your acetyl salicylic acid is now just acetic acid. Obviously, that's not antimicrobial, and it's not even going to be anti-inflammatory, so it's got to go. But it was kind of nice because while people had colds for a week or two while they took their penicillin, which tasted horrendous as a child, those terrible white porous pills, my mother would give me a shot of penicillin and I'd be right as rain in 3 days. So it was kind of nice having that in the house, although I will agree, probably not what I should have done, and probably not what I should have had in the home. So for what it's worth, if we take a look at cell wall stuffs and we kind of move down the road here, we're going to look next at nucleic acid synthesis. And there's a couple ways this might happen. So the first thing is, depending on the drug class, we may block the manufacture of nucleotides. We may stop DNA polymerases from adding new nucleotides or from semi-conservative replication happening. Or you might actually just block transcription in general. It could be you disable an RNA polymerase, you disable a promoter, or you block an operon. Right? Any of that is possible. Sulfonamides, right? So old school sulfa drugs, trimethyltrim, tend to block enzymes needed for tetrahydrofolate synthesis. Some antibiotics, especially in higher concentrations, do that to humans as well. And so sometimes folks are prescribed folic acid on top of it, just so that you guys stay healthy while the drugs go after the microbes. And again, these are older generation stuff. There is second, third, fourth gen stuff in these categories, but they're effective. They work really well. Now, some of these meds work through competitive inhibition, and that's kind of a cool thing. So they become, by concentration, the substrate of choice instead of what the organism is supposed to be metabolizing. If the concentration of the sulfonamide wasn't high, then it would never substitute in to the active site. But because the concentration is high, the substrate is displaced and you're more likely to encounter a drug rather than the natural substrate, which is kind of sweet. And I don't think I've ever shown that to you. I've never shown you what that really looks like. But basically the idea here is, and here's kind of a map of what's actually happening. PABA to dihydroxyfolic acid, to tetrahydroxyfolic acid, to purines, pyrimidines, and amino acids. And so the idea would be to block this enzyme or this enzymatic trip from happening from PABA to dihydroxyfolic acid, or to stop the transition from dihydroxyfolic acid to THFA, trimethylprim. And so we can stop it in either of these pathways, or if we gave you a lower dose of both, right, we would see a synergism. And so you would have less side effects, but a greater action by breaking two pieces of the pathway. And that's really important when you can. This way, if there's resistance here, this knocks it out. If there's resistance here, this knocks it out. And so arguably, it's a better strategy. Now, looking beneath, PABA here is supposed to fit into the enzyme. And you see this lock and key kind of structure. This is not a very frequent product to see around, but it's frequent enough. Now enter the sulfa drug. And if you can get this in a higher concentration so that the enzyme is more likely to bump into the sulfa drug rather than PABA, notice it fits, it binds, and it blocks the synthesis of the next step. Once the drug goes away, so you feel better and you forget to take it, or you've gone through 7 or 10 days and the doctor says you can stop, this will then substitute back in as your body clears the sulfa drug. And so, making sure you don't skip doses and all that stuff is important. It doesn't get rid of the precursors, it just outcompetes it. And I do want to make a comment here. Sulfa drugs are OG. They're definitely an old school thing. Sulfa is naturally antimicrobial. A lot of the times we use it on our face for acne. Got good gram-positive effects. But, and of course there's a but, a lot of people are allergic to them. A lot of people do have allergies to sulfa drugs. And it always starts the same with the itching and the hives, and then it progresses. And I don't know how many folks take them anymore. A lot of it is dermatological, but you do see the allergies and you do see the contraindications. And so just kind of knowing the drug is important. And the sulfa here, it's the SO2NH2. It's that S that gives it its name. And unfortunately, it does give them kind of a smell. Not so much the pills, but if you use the creams, there is kind of that sulfury, earthy, volcanic H2S smell to it. And sometimes it's a put off, but they work. Now, the drugs that block protein synthesis are far more interesting. These generally end up being bactericidal. And because if you wreck the ribosome, you wreck the ability to regulate. No regulation, no enzymes, no metabolism. And so we can get away with this largely in bacteria because we have different size ribosomes. So we can selectively target the bacteria with leaving the host cells alone. And then the question becomes, how effective is it? What kind of dosing is it? How much do you have to take? And so you look at some of the names here, and you see streptomycin and gentamicin, right? That works on the small subunit and causes a misreading of mRNA. So either missense or nonsense mutations occur. Tetracyclines block the attachment of tRNAs to the A site, so killing protein synthesis. Tetracyclines, super effective, unless you're a child, and then you are counterindicated from giving tetracyclines. Is it because they don't work? No, that's not why. It's because of the side effect of causing your teeth to then be discolored. And it actually causes a very strange pattern of discoloration, depending upon when the teeth were growing and when the antibiotics were prescribed. So discoloration and damage to teeth is typically why we don't use tetracyclines in humans anymore. But it has a strong veterinary and like fish tank aquaculture use. You'll also notice that since our mitochondria are technically prokaryotes living in a eukaryote, they retain the ability to self-replicate, they have their own genome. Some medications might actually harm the mitochondria. And so, folks might experience lower energy or feel tired or run down with some of these medications. And obviously, if that happens, speak to your doctor, and they might be able to find you something else or alter the dose. Sometimes it's just about getting past the initial shock and you feel maybe a little better. There's a bunch of ways this can happen. And you're seeing, the streptomycin or the gentamicin here causing misreads. You see the tetracycline blocking the A site. Erythromycin, that's a cool drug, and zithromycin, or azithromycin is the generic, tend to prevent the ribosome from sliding from the A to the P and the P to the E site. So the protein sites are blocked because the mRNA isn't able to move. Erythromycin and the zithromycin stuff are macrolides. So even though they sound a little like penicillin, erythromycin, they are not of the same class. And so if you have an allergy to penicillin or amoxicillin, you'll probably do well on erythromycin or azithromycin. They're very effective. And the idea of a Z-Pack fits in here. Whenever you have a respiratory and the doc gives you a Z-Pack, It's not cheap, by the way, to give you a Z-Pack. Insurance only charges $2.50 for my Z-Packs. The reason why they're willing to give it to you is not because it's easy to formulate, but because compliance is through the roof. Zithromax, erythromycin is well tolerated in strep and or other type of respiratory infections with few side effects, and you only have to take 5 pills. If nothing else, that is the greatest draw. I take 5 pills total and I'm done. Notice we've got chloramphenicol here. Chloramphenicol blocks the peptide bond formation. So it interferes with the P and the A site. And you'll notice that there's a couple meds here that will interfere with the initiator, so the methionine tRNA, and it will prevent the large subunit from associating with the small subunit. Any of these are good. A couple of these are even better, especially with TB. The trick, obviously, like all of them, is to finish your medicine. Now, if there's going to be a side effect, it may be a little more severe with some of these, only because of the inhibition of protein synthesis. Likely, if the drug was designed well, you will suffer very low or nil effects. So you'll do pretty well. What else do we want to show you here? Oops, too far. Yeah. So the idea of getting rid of cell membranes is a really good one. And obviously, I mentioned earlier, phospholipids are a problem. Ours look like everybody else's. So we have a choice. One of the things we can do is go after the cholesterol, go after the steroids. And that's a good way to do it with funguses because it wrecks membrane fluidity. And so if you wreck the fluidity of the membrane, you can wreck the transport. If you wreck transport, those cells really have to rely on what's in the cell. And eventually, the metabolites will kill them. It's just going to be toxic. Oftentimes, though, doing this internally is really not a good idea, obviously, because we're made of phospholipids. So when you see what we're using, polymyxins, amphotericin B, both of those are components of typically triple antibiotic ointments. You can throw into there mupriacin, which is derived from an acid product that does something very similar. Nystatin is an interesting one. Nystatin can be topical. I don't know of anybody taking it internally. I guess you could. And nystatin is super effective because it goes after the steroids. And so one time, and again, I'm just a mess. I ended up working a long stretch, and I'll be honest, this is when I was still drinking, and I just kind of neglected my health. And I got itchy. My feet were itchy, and I just kind of kept scratching and scratching and scratching, and this rash was flying up my leg. And I remember I was living in Malaw, so I went to the Airmont Urgent Care, and I went in, and I'm going to be kind. The doctor was very new and was not sure of what she was seeing because a lot of what I present is abnormal. I'm going to be kind. And so I suggested to her that it was athlete's foot and that she should give me something for it, like nystatin. And she did. She said, all right, you want nystatin? It's yours. And I guess it was a pill. And maybe she gave me a cream with it. And within 5 days, it was gone. The rash was gone. The itching was gone. Again, though, in old school medicine, results may vary. So there's certainly other antifungals. And I have some in the cabinet. They work differently than necessarily amphotericin, but stuff like cyclopyrox is a good medication if someone has a fungal infection. So we have a lot of options. And the fact that the sterols are different in a fungus makes it a lot easier. We know we're not going to hit the phospholipids. We're going to go after the steroids. And since there are differences, we can make that work. And if you look at some of the pictures, what you're really doing is disrupting the membrane. So if we could drink soap and make it work, we would, but we can't. So these drugs make or work like soap, and they make the cell membrane leaky. And once they're leaky, that's it, right? Water rushes in and kaput, the cell is dead. So these are pretty helpful to know, pretty important stuff to see. And as new meds get made, they're probably going to fall into one of these categories, right? It's going to be break the cell wall, break the cell membrane, go after protein synthesis, or stop and block products that we need for metabolism. And it's really up to the sensitivity and or what's around and or what your body tolerates as to what works best. You know, the old saying, different folks for different strokes. Different strokes for different folks. That's what it is. All right, so certainly there's other stuff we probably care about. The antibacterials, antibiotics, synthetics, sure. The antifungal drugs, there's a plenty of them. And they all work, but again, many of these are topical. The ones that are systemic, the ones you take orally, can be really hard on the body. Sometimes, and I know yeast infections are very treatable with stuff like monostat, which is essentially a topical, but diflucan does wonders for some women with the with yeasts. Sometimes the best antifungal drugs may be not even drugs themselves. And we've talked about the idea of, you know, where's the fungus and should it be there? In the case of, you know, underarm fungus or in folds or under breasts, sometimes, yeah, tenactin is great. Sometimes, yeah, nystatin is good. Sometimes deodorant is better. If you can kill the conditions that make the fungus thrive, then sometimes your body deals with the fungus. And certainly if you're over a fungal infection and it's an external one, keeping your areas dry and clean is one of the best preventative methods. You've got antivirals. Yes, you do. And these target a lot of things. I do want to just mention that the antivirals we have to be careful with, because viruses are obligate intracellular parasites. You are going to do a job on yourself. Now, it really depends what the medication is. And if we use HIV, which probably is like the kitchen sink of things we do in cocktails, we can go after the enzymes. We can go after the reverse transcriptases. We can give it protease inhibitors, and that would kind of work on a lot of the enzymes as a generality. With HIV, we also make fake nucleotides. So AZT was the first one on the market, and AZT is a thymine analog. It looks like thymine, but it's not thymine. And so when it's incorporated into the growing nucleotide strand, it doesn't hydrogen bond, it doesn't base pair properly, and so the cells then die. Or shall I say, the viruses can't replicate, and the viruses that are made are faulty. Cells aren't dying, although that isn't exactly the problem with HIV. There's also antiparasitic drugs. Some of those are very interesting. Some of those are very simple. Flagyl is antiparasitic in some respects. Quinine is a really great one. And there's a whole host of them for different protozoans and different helminths. I have found them, aside from Flagyl, to be fairly well tolerated. But again, results may vary. And so we're looking at about 260 common drugs in roughly 20 different families. And this is for basically our day-to-day stuff, right? So when we look, penicillins and cephalosporins are pretty obvious. Other beta-lactam antibiotics that have the lactam ring are obviously important here. Aminoglycosides, so your streptomycins, for example, fit in there. Tetracyclines and their derivatives, got to throw those in. Chloramphenicals and their derivatives. Other streptomyces antibiotics, so from the genus Streptomyces, the genus Bacillus, and then we're kind of deriving some new stuff. And they're not very common, they're kind of far and few between, but you have seen stuff to treat VRE. We do have Levaquin now, and so it's minocycline and doxycycline, although those fall under tetracyclines antibiotics. We're just not making a lot of them. And I hate to say it, the golden age of microbiology with respect to these is over. It used to be in the 60s and 70s, if you had the clap, you got a shot. If you had gonorrhea, you got a shot. And it cured what ailed you. It really did. But resistances and new strains and emergent strains from strange places and new things we've never characterized before really threaten us. And so when these drugs don't work, what do? There are people who are using bacteriophage. That's typically Ukraine is from what I understand, the old Soviet republics, some of them. And we're also looking at targeted protein therapy. So kind of tagging the bacterium so that the immune system can recognize the tag and deal with the tag rather than a surface protein or an antigen. It's an interesting thing, but obviously it doesn't cost $2.50 like my Z-Pack. And so we're going to have to be watchful and careful, and it may, quite frankly, involve our modification further of our behavior. If you're looking for some of these anti-malarial, anti-protozoan drugs or anti-helminth drugs, here's some brand names. And the helminth drugs are particularly interesting because of what they usually do. And while some of them are poisons, like for pinworm, some of them actually destroy structures. And so with a tapeworm, the medicines actually destroy the scolex. So in the head, there's suckers and spines that anchor a tapeworm into the body so you can't pass it out. If you, and this is simple language, if you melt them, they have no way to anchor themselves, and you're going to pass a very large, potentially tapeworm. In the case of nematodes, so roundworms, a lot of the times they like to hang out in your rectum, and they'll use the proboscis on the tail to puncture the rectal lining and anchor themselves in. In some cases, like with elephantitis, they penetrate into gonads. And so what you see there is more of a poisoning and a disabling, and then your body reabsorbing them more than destroying and being able to pass them out. In terms of our quinine, quinine is cheap. Quinine is a great drug. Dollars, pennies a day, dollars for a year. It doesn't work anymore. There's resistance. And so chloroquinine, pretty effective, a little more expensive. And then the derivatives here are second, third, and fourth generations. Notice the protozoan drugs overlap with a lot of antibiotics. So you see the tetracyclines, the sulfonamides. Likely it's the sulfur doing it, not the competitive inhibition. The flagyl, gram-negatives and protozoans. So fortunately, we don't have to necessarily make new stuff. We might be able to go back into the annals of history, find drugs that we don't give anymore, and repurpose them. And certainly, since they're approved already, it's a lot easier to get them on the market to the people who need them, get them into your hands, than it would be otherwise. And so these are good things, even if these names are very strange and they haven't been in common use for a while. Antivirals, and here's some really good examples. We mentioned some HIV stuff, but obviously herpes and HPV, and certainly other medications. Acyclovir is a really great one for herpes and for simplex, and actually for molluscum too, as it turns out. But essentially what we like to do here is stop the absorption, stop the penetration, and if we have to, stop it from being able to leave the cell, and at the very least, block the transcription and translation. And that's where a lot of these analogs come in. AZT is the classic 1980s version. There's an ACT, an AAT, and an AGT, for lack of a better name. I'm sure it's not called that. But we make synthetic adenines, guanines, cytosines, and thymines now. And then lastly, you see something called interferon. And I just remember The Simpsons saying, "You're interferon with my good time." And it makes me laugh every time. But in our bodies, we produce natural interferons and interleukins. They're there to be part of the viral mediated response that involves T cells. And so folks have been able to synthesize human interferon, and there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and so forth, to give to folks that have just a general viremia and allow it to be effective, kind of less harsher, but I will tell you it is very expensive to have an interferon infusion. And so they don't do this for everybody. I also probably should throw in here antibodies or antibody infusion, because we're really seeing that now with COVID. Right? And the rebranding of old medications is also kind of a hallmark of COVID. And so I don't want to say the old cliche, everything is new again, because well, that's lame. But it's true, you know, and if we can find something that's already there that works, that's cheaper or effective, then that's what we're going to try and do. And for what it's worth, these are typically given in cocktail, at least in the case of HIV, because immunity is hit at some point by HIV to the AZT. And so a cocktail needs to be given just so that you can prevent the accumulation of mutations and resistance from happening. Notice this med here works against hemorrhagic fevers. So Lassa fever, Marburg disease, which is caused by another hemorrhagic fever, and Ebola tend to be good candidates for this type of approach. Antibodies are used, especially in people who have survived Ebola and have been very effective. But to be honest, the Ebola of today is not the Ebola that our grandparents knew. And I know that sounds the weirdest of all to say, but the Ebola of the 70s was much more dangerous, much stronger, much more horrendous than the Ebola of today. It killed almost 100% of the people who got it. Today, we're looking, and this is not a trivial number, we're looking at between 3 and 4 in 10 will die. On the bright side, 6 to 7 people are going to live. And that's all thanks to these drugs and some of the antibody therapies that we've been able to develop. Again, not cheap. And so the people who need these often do not get them. And if you looked at a map today of Western Africa, you would probably see Ebola being endemic in some of those places. Sierra Leone, Liberia, what else is over there? I should know my geography a little more. Maybe, no, I'm not even gonna say it. So those people really could use these meds, and those people really could use generic versions, or a country to purchase it and give it to them, for them. And quite frankly, that's what the World Health Organization should be doing. And I just don't see enough of that. The UN should be doing that too. Unfortunately, with the good, we have the bad. And kind of the last takeaway to the drug piece here tonight is going to be that these things aren't forever. And we have to be responsible in how they're dosed, which is why they're by prescription. We have to be more on the educational tip, especially with parents and children who are outside of the healthcare realm and just want to see their child better. Parents will ask for things that don't work because they think it'll make their child feel better. People won't leave a doctor's office without drugs because they think that drugs are the only way to make their children feel better. And I know this is a westernized medicine or medical oriented kind of class, but you have to recognize that there's other ways sometimes to treat a child, and that the overprescribing of antibiotics is definitely something we have to chill on. Ear infections, probably the number one thing that drives parents to the doctor with their children, and probably 8 in 10 don't need an antibiotic. 8 in 10 would benefit from a saline wash and some Tylenol. However, having been the child with ear infections, it's miserable. It hurts. It sucks. You cry, you spend time in bed, and your parents feel miserable for you. So I get it, and I understand why. It's just an education piece. We have to chill with it. Sometimes it's the dosing. We don't give you enough, and you breed resistance. Sometimes it's our own virtue, right? We don't take enough, and we create these things. Now, I'm not saying that it's all human driven, and it's not. The bacterium too, with their generation time of 20 to 40 minutes, just have an advantage. They outcompete us. They're able to try new variations more frequently, more often, and quite frankly, they kind of have to. And so there's some organisms that when you're beating them up, or when they become numerous, they actually switch metabolic pathways. They have, I'll call it alpha 1, and then when you challenge them, they go to alpha 2. Now the drug you're challenging them doesn't work. And obviously the change in receptors, whether this is viruses, whether this is bacteria, in the case of gram-negatives in some of the formulations, whether it's a fungus and a steroid, if you change the place that the drug is looking for, the drug is no longer useful. And we see a lot of that in tuberculosis. And it's not that you've done anything wrong, it's that the bacterium is just responding faster than we can. And that's why this war wages on. Just looking in chat here. Yeah, that's one of the biggest things. It's ear infections, and I want to say followed by strep throat. And I'm not saying you shouldn't treat strep, but if you are somebody who has chronic strep or sinus infections, then you probably should dig a little deeper rather than just throwing more antibiotics at it. There might be an underlying cause. I have a staph predisposition. That just seems to be my curse. It probably lives in my nasal passages. It just is harbored because of my body chemistry. And as long as it stays where it stays, okay. But obviously it's causing me some grief. It's causing me some swelling and some inflammation. As I look down, My little piggies do look less like roast beef, but they definitely don't look very happy. And so, sometimes there is a little bit of trial and error here, but if we can do things to minimize resistance, two things happen. The stuff we have now works longer, works maybe better, and the cost of drug discovery goes down. If we don't take precautions, we're going to find ourselves in a place where we don't have agents of control that work anymore. And I know we're seeing this now, with urinary tract infections that predominantly affect women. There's no more drugs. Klebsiella is completely drug resistant in some cases. We have nothing else to throw at it. If Staphylococcus becomes vancomycin resistant, what are we going to do? Right? That means a boil or a pimple could actually kill you. And it seems to me that in 2020 part 2, that's not so far-fetched, but it also shouldn't be happening. And so I really don't know what it's going to take from a philosophical point of view. Maybe we need to observe Canadian scientists or Brazilian scientists or Zimbabwe scientists or a Somali scientist. I'd see what they do differently, see how it's approached differently. And just to talk at the beginning of the class about why is Haiti so low against an infectious agent that really doesn't discriminate. Everybody is got ACE2 receptors in the body. What is it about what they're doing that's helping the immunity? I would love to know. They're still humans, right? They still have hearts and type A or type B or AB or O blood. So what are they doing differently, void of apparent intervention that's been so successful? We stand to learn a lot. And I just hope the folks that are in positions to learn aren't going to be stupid. They're actually going to be smart and cure their ignorance with some conversation and some study. I really hope that happens. And otherwise, I know it's early tonight, but I'm not in any rush, and I don't think anybody else is. And so unless there are comments, and I'm all about those, if there's some concerns, we'll take those also. Criticisms, why not? I'm not trying to keep anybody longer than I have to tonight. So at 7:40, let me just make a couple announcements and get some feedback, and I will let you guys have the rest of your weekend back. Registration for summer is on. And I've been bombarded with people trying to get into micro. Thankfully, that doesn't affect you guys. Chemistries are starting to fill if you guys are looking for an inorganic for the summer for the purposes of your BSNs. If you are, and any of the sections are closed, reach out, let me know if it's for you guys. And I'll see if I can't make an extra spot or two appear in the Chem 101 that I'm doing. I'll have to take extra students and overload it, but that's okay. Fall registration is not started yet. It was supposed to have started already, and maybe next week it begins. Check your student emails at RCC for that information. The Senate and the administration had a very interesting conversation this week. And basically, that is the official means of communication. And so I know it's rather disruptive to check because of all the bulk of emails, but I don't want you guys to miss seats that you need, especially at the point at which it means your clinicals, your process courses, and maybe that random psych class that there's only one section of it you have to have. So that'll open soon, but the schedule is on Banner for your perusal. The semester is supposed to end on the 17th. Anybody who's graduating with an associate's in science while you're on your way to your nursing degree, there will be some version of an in-person graduation. I know it's going to be small, and I think you guys will be able to attend. I think your relatives may have to stay outside. It may be broadcast. Unsure how that's going to look yet, but that's on the horizon. And obviously, May 17th is a day that we're going to enjoy. That is the last official day of our semester. So on the 11th, which is a Tuesday of May, I expect all folks will have their papers uploaded by then. I've checked in on them here and there. I've made comments with respect to similarity scores where I can. If you wait until the 11th, it's going to be super duper hard for me to say, by the way, your paper is not your own. Could you do a revision? Oh, by the way, you've got 3 hours. So I'm not saying you have to upload it early, but anybody who has, I've been able to provide some feedback. You certainly don't have to upload it for feedback. I'll look at it anyway. So just realize that. And then I need your help. I probably need one more lecture at least, but I can make it in one for the last unit. And that really has to do with epidemiology and the host microbe response. We could potentially have an exam after the week of your practical, after the practical, but I'm thinking more likely it would be beneficial for folks to have it on the 12th, 13th, and 14th. So really that last week of the semester. And I hate doing that, but I don't want you to have a crunch or get slammed around your practical time. So that's kind of my thought there. If anybody wants to provide comments or concerns on kind of the calendar, I'm all ears, but I'm trying to make it as easy on you as I can. Doesn't matter to me. I'm going to get slammed on the 17th anyway. So if anybody has an opinion one way or the other, yeah, I'm seeing a couple in the chat here.
Like the 12th.
Just let me know. Or unmute your mic and tell me, Duranda.
I'm sorry, I thought I said that the 12th and the 14th works for me.
Yeah, that seems like a reasonable plan. I don't know what your nursing processes look like. I don't know what your other classes look like. So if you can guide me, I'm certainly willing to give you guys that hand because like I said, I'm going to get beat up anyway. So if I can help you guys out, so be it. And otherwise, go ahead.
Our cumulative final is the 17th, the last day, so
In what class?
in 231.
Oh, is that Professor Lasman?
Yes.
Oh, you'll be fine.
Yeah, she's
You'll be
great.
fine. She's good and she really wants you guys to succeed.
She really does. Genuinely, she really does.
She really does. So if you have her this semester, she is a very welcome addition to the nursing faculty. And I've seen a lot of folks come and go. You're going to do really well with her. So breathe a little easier, but I get it. That's going to be a stressful afternoon. So that sounds good then. I'll sandwich it then. It's just going to be the 2 chapters, the 3 chapters. So that works out to, is it 11, 12, and 13? Or is it 11, 12, 13, and 14? I'll check the syllabus and I'll remind everybody next week. All right, folks, you guys have been awesome as usual. Happy weekend. It's a little cold today, tonight, but as we've seen, it's going to be in the 80s pretty soon. So stay well, be healthy, and I'll catch up with folks next week.
Take care. Have a good night.
You guys too.
Thank you, Professor. Have a good one.